Good evening, everyone. I'm Dr. Shailesh Gupta. I'm a laparoscopic, robotic, and bariatric surgeon from MasteringBaileyandSabiston. So today, we're going to continue our stomach series in Mastering Bailey and Sabiston page by page. Here we are covering each paragraph page by page. We are going topic by topic. So today, I'm going to cover peptic ulcer disease part 1 in the stomach. Previously, we discussed about the anatomy and physiology. This is the third part in which we are covering the peptic ulcer disease, right? So this will be a flow of lecture. As any other lecture, there will be few MCQs. Then there will be simplified text, figures, and table and boxes, which I have taken from the Sabiston and simplified in a very simple language. And after that, there will be post-test. In the post-test, I'm going to discuss about the answer of the pre-test. So what I'm going to give a lecture on, we're going to discuss about definition, epidemiology of peptic ulcer disease. We're going to discuss about pathogenesis. We're going to discuss about the clinical features, diagnosis, how will you diagnose the peptic ulcer disease, and also we're going to discuss about the medical management. Surgical management will be discussed in the other lecture, other part, on the part 2. So what is the definition of epidemiology of peptic ulcer disease? So peptic ulcer disease is defined as erosion in the gastric or duodenal mucosa that extends through the muscularis mucosa. So Sabiston very specifically defined peptic ulcer disease at the erosion in the gastric or duodenal mucosa that extends through the layer muscularis mucosa. So just remember that muscularis mucosa का breach को हम peptic ulcer disease बोलेंगे gastric और duodenal mucosa के अंदर. And what is the incidence prevalence? Incidence is 0.1 to 0.1% annually, and prevalence is 0.12 to 1.5%. So you can see that it is quite a common disease, right? So it is very important to know that the incidence of the and prevalence of the peptic ulcer disease is declining in the developed countries, right? And it progression to the complicated disease like perforation and gastric outlet obstruction is also decreasing. So overall disease is decreasing. This is very important point. And what are the factors which are leading to decline the peptic ulcer disease? Number one, now we know the exact cause of the pathology of the peptic ulcer disease. Now we know how much important the H. pylori is in causing the peptic ulcer disease, right? And we also know about the long-term risk of NSAID use that they can also cause a peptic ulcer disease. So as we are aware of the etiology, we know how to prevent it. So that is the reason that there's a decline in the basically prevalence and incidence of the peptic ulcer disease. Moving on to the role of surgery, का क्या change आया है in the past decades? The role of surgeries has decreased in the peptic ulcer disease because now the complications are happening less, so their role are decreasing, but the percentage of the patient requiring emergent surgery for complicated disease remain constant, right? So overall rate has come down because the overall incidence has come down, but still the surgery which is done for a complicated disease remain constant. So now the next important topic is pathogenesis. So these are the few questions pre-test. Which is not damaging factor for gastric mucosa? Number one, pepsin, endogenous prostaglandins, ethanol, and NSAID. Question number 2, what type of bacteria is H. pylori? Gram-positive Spirilla, gram-negative Spirilla, gram-positive Bacilla, gram-negative Bacilla. So basically, H. pylori किस type का bacteria है? Question number 3, which of the following is not a potential mechanism responsible for H. pylori-induced GI injury? Production of toxic products, induction of systemic immune responses, increased gastrin levels, or gastric metaplasia in the duodenum. So in चारों में से कौन सा mechanism से H. pylori injury नहीं करता है? Question number 4, where are the NSAIDs induced ulcer most frequently found? Duodenum, stomach, esophagus. It is found equal in both stomach and duodenum. So what percentage of patients with duodenal ulcer have acid output within the normal range? 10%, 30%, 50%, 70%. Question number 6, which type of gastric ulcer behave more similarly to the duodenal ulcer due to gastric acid hypersecretion? Type 1 and 4, type 2 and 3, type 1 and 2, type 3 and 4. So these are the very important questions which are clearly answered in the Sabiston. So now start the text. So there are certain protective factor, there are certain aggressive factor जो mucosa को protect भी करते हैं और जो mucosa damage भी करते हैं. So factors which protect the mucosa are mucosal bicarbonate secretion, mucus production, blood flow, growth factors, cell renewal, and endogenous prostaglandin. So these are the factors which protect the mucosa. Now there are other factors which damage the mucosa like acid, pepsin, ethanol ingestion, smoking, duodenal reflex of the bile, ischemia, NSAIDs, hypoxia, and most important is H. pylori. So ये सारे factors हमारे mucosa को damage करते हैं. So now the first thing we will discuss in the pathogenesis is H. pylori. H. pylori सबसे important factor है peptic ulcer disease cause करने के लिए. So H. pylori is a gram-negative rod with 4 to 6 flagella, right? It resides in the gastric type epithelium within or beneath the mucous layer, and it protects this mucous layer protects from the acid antibiotics, right? And it produces the enzyme urease, which split the urea into the ammonia and bicarbonate. So because of this bicarbonate, there is an alkaline microenvironment in the acid gastric villi. So this is how the H. pylori protect itself by creating a alkaline microenvironment around himself. Number one, also it lies beneath the mucous layer. So mucous layer is also protecting it. So just remember that rapid protease urease test is a method by which we can diagnose the H. pylori, rapid urease test. So moving on to, just remember that H. pylori एक micro aerophilic organism है and it can only live in the gastric epithelium. That is why H. pylori can be found in the heterotrophic gastric mucosa, in the proximal esophagus, in the Barrett esophagus, in the gastric metaplasia, in the duodenum, within the macral diverticulum, and in the heterotrophic gastric mucosa in the rectum. So जहां हेटरोट्रोपिक गैस्ट्रिक म्यूकोसा मिलेगा वहां पे भी H. pylori मिल सकता है and H. pylori exclusively gastric epithelium में मिलता है. If it is found in the duodenum, this means that duodenum has a gastric metaplasia. So now comes very important part. H. pylori is the main culprit in the peptic ulcer. 80 to 95% of duodenal ulcer are caused by the H. pylori, and approximately 75% of the gastric ulcer are associated with the H. pylori, right? That is why eradicating H. pylori as a part of ulcer treatment results in extremely rare chances of recurrence of ulcer. एक बार आपने H. pylori को आपने eradicate कर दिया, बहुत कम चांस है कि पेशेंट को अल्सर रेकर होंगे. So now the next question is कि H. pylori कैसे GI injury cause कर रहा है? So there are 4 mechanisms. Number one, production of toxic products. So basically the breakdown product of urease activities, cytotoxin, mucinase, phospholipases, and platelet activating factors are basically byproduct of the bacterial activity, and this all lead to injury, right? Number 2 is it induce local, not systemic, it induce local mucosal immune response. How it basically cause a local inflammation. It result in the attracting neutrophil and monocyte, which produces the pro-inflammatory cytokines and reactive oxygen metabolite. So this also leads to GI injury. So point number 3, it also leads to increased gastrin level. Gastrin level lead to increased acid level. Number 4 mechanism is in the duodenum. Because of the increased acid level, there is a gastric metaplasia. This is the basically a way of duodenum to protect itself from the increased acid. So duodenum basically एक adaptive gastric metaplasia cause करेगा. Because of the gastric metaplasia, H. pylori will colonize, and this will lead to duodenitis, and this will lead to predisposition of the duodenal ulcer formation. So there are 4 mechanisms. Number 1, it toxin product release करता है. Number 2, it causes local inflammation. Number 3, it increases gastrin level. Number 4, it causes gastric metaplasia occurring in the duodenum, because duodenum का एक protective mechanism है अपने आप को एसिड से बचाने का. तो उस gastric metaplasia के अंदर हमारा H. pylori organize हो जाएगा, और this will cause duodenitis, and this will lead to duodenal ulcer formation. So H. pylori, apart from causing ulcer, can also lead to high chance of gastric cancer. This is a proven strong association of H. pylori with the CA stomach, right? And it is also seen that H. pylori also causes mucosa associated lymphoid lymphoma. So बहुत important है कि duodenal ulcer, gastric ulcer तो cause कर ही रहा है. Apart from that, it is also causing gastric cancer. It is also causing lymphoma, mild lymphoma also, right? So this is very important कि H. pylori इतना important topic है कि इस पे Marshall and Warren were jointly awarded in the Nobel Prize recently, not long before in 2005 for their pioneering work connecting with the H. pylori with gastritis and POD. So guys, जब से हमें पता चला कि H. pylori was a main culprit, इस पेप्टिक अल्सर डिसीज के एरिया में काफी चेंज हुआ है, राइट? सो H. pylori को A to Z पढ़ना बहुत इंपॉर्टेंट है हमारे MS एग्जाम के लिए, ऑल्सो फॉर नीट SS एग्जाम. So now we have discussed about the H. pylori pathogenesis in the peptic ulcer. I'm going to discuss about the next culprit, basically NSAIDs. So basically